Hello and welcome. On behalf of CME Outfitters, I'd like to thank you for joining us for this four-part CMEO snack series titled ADHD Can Be a Moving Target. Equip yourself with the tools to detect and manage ADHD to reduce its burden. Today's episode is titled Empowering Patients to Make Informed Treatment Decisions in ADHD, What They Need to Know. This CMEO snack series is supported by an educational grant from Takeda Pharmaceuticals, USA. I'm Dr. Ann Childress, president of the Center for Psychiatry and Behavioral Medicine, and I'm also an associate professor in child and adolescent psychiatry at Touro University, Nevada College of Osteopathic Medicine, and a clinical associate professor at the University of Nevada, Las Vegas School of Medicine. I'm joined today by my colleague, Dr. Scott Collins, Chief Medical Officer of Holmusk and an adjunct professor of psychiatry and behavioral science at Duke University School of Medicine in Durham, North Carolina. Welcome, Scott.
Thank you, Anne. It's nice to see you again and really look forward to our discussion today.
It's great to be with you, and I'm looking forward to learning from you. To frame the discussion today, let me review our learning objectives. Our goal is that after this CMEO snack, you will be able to educate patients and caregivers about the available ADHD medication profiles, behavioral therapies, and significance of adherence to therapy. Scott, both non-pharmacologic and pharmacologic therapies are important components of managing ADHD across the lifespan. What are some of the non-pharmacologic strategies for managing ADHD?
Yeah, well, there's a lot, and I think we'll talk about it a little bit later. Just like there's a lot of medications and pharmacological treatments, there's an awful lot of non-pharmacological treatments too. And I want to focus on ones for which we know work. That is, they have some clinical evidence, and it depends a little bit on what you're targeting, because treating ADHD, just like the title of the overall series, it's a moving target, and you can treat lots of different aspects and facets of the condition. And I'll start by highlighting there's actually a couple of treatments, non-pharmacological treatments for ADHD that are cleared by the FDA, which primarily means they're triggering specific aspects of ADHD symptomatology or severity. One's a digital therapeutic, one is a trigeminal nerve stimulation device. Now, those are in a little bit of a unique category. There's also a really big category of non-pharmacological treatment options with a lot of evidence behind them that we can think about really broadly in the category of behavioral therapy or behavioral modification. And these things include things like psychoeducation, specific behavioral interventions where you're teaching a patient themselves, in the case of adults, or the caregivers of kids with ADHD, how to structure the environment and how to apply consequences in a way to change behaviors. There's social interventions to help kids with ADHD and adults, but mostly for kids, how to improve their peer interactions. And then there's more traditional psychotherapy, which can focus sometimes on some of the cognitive elements of ADHD. So there's a lot, and educating parents, educating adult patients about all of these is really important.
Got it. Well, you and I have worked on a number of drug trials for ADHD. So tell us a little bit about the pharmacologic therapies that are available for ADHD and how they differ.
Yeah, so like I said, there are a lot. I don't have a count in my head. It used to be something like 25 or 27 either branded or generic medications that were approved specifically for ADHD. I like to think about breaking them up into a couple of different categories. So one big category is stimulant medications, and these are the most commonly used. These have been studied for the longest period of time. The first randomized controlled trial of methylphenidate, which is one type of stimulant, was conducted in the mid-1960s. So they've been around for a really long time. Lots and lots of trials focused on them. And in that bucket of stimulants, there's two different medications. One I just mentioned, which is methylphenidate, and a different drug, which is amphetamine. The main difference between these two molecules themselves is I don't think it's terribly relevant for the actual clinical treatment of ADHD. It has to do with how they facilitate dopamine transmission in the brain. But they do, from a clinical perspective, they do have they're different. I know that, and you can probably talk a lot about this, they have a different clinical feel. Typically, amphetamine tends to be a little bit more potent on a dose-by-dose basis. The side effect profile might be a little bit different. Within each of these categories of methylphenidate and amphetamine-based stimulants, there's still multiple different products that are available. And the biggest way to characterize the differences across those different products has to do with their formulation, how they are formulated to release the medicine in the body. And that's really, I mean, in some ways, it's a disadvantage to have so many, because it can cause, I think, some confusion, and it's a little bit hard to understand what the differences are. But I think there's a real benefit, because it gives clinicians a lot of flexibility to think about. I know that the time profile for this particular medication might suit a patient and their needs a little bit differently. Now, I've just been talking about stimulants so far. There's also a small but relatively a growing class of medications we think about as non-stimulants. Now there are, four now approved non-stimulant medications to treat ADHD, and these are just the easiest way to characterize them is they're not methylphenidate or amphetamine. So their mechanism of action from the way they work in the brain is just a little bit different. And similarly to having flexibility about the formulation, having non-stimulants is really important, because you might have kids that or adults that have specific side effects or not able to tolerate a stimulant, and you might have a non-stimulant that could really help with that. And non-stimulants have a little bit different profile of how they work, or the kinds of things that they might be beneficial for. So lots and lots of different options. We don't actually have a lot of good data on any kind of comparisons across the different products. So this is where our clinical science sort of spills over into clinical judgment and clinical art in terms of making good choices about what's going to work for our patients.
There are so many, and I think at last count, there were more than 25. There were about 30, if you can believe that, with some more coming.
Yep, exactly.
And then a number of the brands have different generics. For example, Oros methylphenidate, at last count, there were 9 different generics. So it can be,
I did not know that.
It can be really difficult to figure out what to do, and patients may get one generic one month and another generic another month. And so it can be quite a daunting task for the clinician if somebody's taking a medication and they come in and say, I'm having some side effects and my pill changed. And if they don't have it with them, we don't know what's going on.
Yeah.
One of the things I recommend to clinicians is be familiar with several of them. Be familiar with some of the methylphenidates that kick in quickly, some of the methylphenidates that may last a little bit longer in trials, and really get a good feel for them, so that if one of the kids is having problems on the bus getting to school, that maybe they're going to do something, treat them with something that kicks in a little bit more quickly, or if safe key in the afternoon is a problem, something that lasts a little bit longer. But it is definitely a challenge to keep up with everything. And the only reason I can is because I do the trials with most of them. So anyway.
Yeah. Well, but you're even doing the trials, it's still sometimes hard to keep track of all the different ones. You're exceptional in that regard.
Oh, well, thank you. Thank you. So patients clearly have many treatment options for ADHD. And as clinicians, it's important for us to provide them with sufficient information to make informed choices. But even when that occurs, even when we have them on our team, or we're team members, we're developing personalized treatment plans, adherence is less than ideal. And I used to think, no, it's not with my patients when I see somebody only fills 1 or 2 scripts, but it happens all the time. I'll have not seen somebody for 6 months. I've written them 3 months medication at the last visit, and they tell me they're taking it every day, yet it's been 6 months and there are 3 prescriptions. So I know that at least half the time they haven't been. Talk a little bit about the barriers to treatment adherence that you found.
Yeah, this is such an important topic, and I think what you described is definitely more the norm than it is the exception. There's a lot of studies that have shown that if you track people's refills over time, by the time you get 12 months out, a small minority of patients are still taking medication. And this is like it's hard to reconcile this when we look at the clinical trial results because these wouldn't be approved if they weren't effective. Now, I think that one of the biggest barriers to adherence has to do with what the medication is treating and what the expectations of the patient or the caregiver are going into that. All of our trials and all of our studies, in order to get approved, we're measuring a pretty discrete outcome. We're measuring symptoms as measured by a rating scale. But we know that ADHD's got a lot of other kind of collateral damage that goes around just having those symptoms. It has to do with their functioning in different aspects of their lives. So if a patient goes into their treatment regimen with the expectation that as soon as I start taking this medicine, all of this is going to magically clear up, that's going to get frustrating. And I've seen this, as a psychologist, I don't write prescriptions, but I see this in my patients where we'll do an assessment. We send them away from their initial diagnosis with recommendations to get medication as well as to get some sort of non-pharmacological treatment, recognizing that the evidence tells us that those two things combined have the best chance of success. And we hear back from them in 2 or 3 months, like you said, and they say, we started on the medicine and it's just not working anymore. It worked great for a few days or for a few weeks. And we say, well, what about that other recommendation? Oh, yeah, we haven't gotten around to that yet. So it's not that the medicine stopped working. It's that they took the medicine. They saw immediate effects on the sort of central parts of ADHD, but without, in combination addressing some of those other things, it can get tricky. We also have to think about we're treating patients who, by definition, have difficulty remembering things and staying organized, and so forgetting their medication, losing their medication. Certainly forgetting to refill prescriptions. I have to refill my prescriptions sometimes, and it's a challenge to fit into a busy day and remember to do it. And oh gosh, the pharmacy's closed now. So, and I don't have ADHD, so that can be a barrier as well. So I think all of these things, and it's going to be unique for different patients, but the bottom line is that there are a number of patients, and like I said, the majority of patients are going to end up being non-adherent over time, and that's important for us to think about how can we mitigate that.
Scott, are there differences in racial disparities with treatment adherence?
So the short answer is there is. And what that looks like is that in general, if you look at things like claims data, insurance claims data, so looking at those data and looking to see who refills their prescriptions, what we see is that kids from underrepresented minority groups, from Black or Hispanic groups, tend to have those gaps in their treatment showing up sooner. I have to caution on interpreting findings like that because there was just a recent paper, and some of the work that I've been involved in recently has highlighted some of the inherent biases that we have. We know that there are big disparities in healthcare. It's a very interesting study that looked at electronic health record data in a large number of patients and found that there were, even in the subjective notes of the clinicians, there were significantly greater numbers of negative words like non-compliant or other things like that. So we have to be careful in how we interpret the fact that we do see greater non-adherence in some of these minority groups, because the way that this information is communicated to them and the way the prescriptions are being written may be a setting event for them to then have difficulty, and it might just contribute to some of those barriers we talked about earlier.
Wow, that's really interesting. I'm going to have to really think about what I'm saying and how I'm saying it. I know that I probably have an eye roll when my teenagers come in. Over the past couple of years, though, I've been more popular with those early teenagers. For at least a time period when there were lockdowns, I was about the one outing that they got. So,
Oh
and
my
they do have
gosh.
a therapy dog, which is really helpful. So with that in mind, yeah, they come to see Buddy. They don't really come to see me, but Buddy hasn't mastered writing prescriptions yet because he doesn't have that opposable thumb. With that in mind, do age and gender play a role in treatment adherence?
Yeah, they do. They do. And we can think about this as another barrier. I mean, you mentioned the early teenagers. I mean, not surprisingly, we see adherence rates decrease as children get into that, or as adolescents get into that transitional age to young adulthood, such that, you know, when they go from 17 to 18 to 19, the adherence rates are going to go down. We see that for both boys and girls. There's not huge differences between genders. So yeah, the older you get, the less adherent you are. And you know, if we think just clinically, lives get more complicated. You know, kids as they get into their later teenage years, they may be going off to college, they may be moving out of the home, at the very least probably less likely to have a caregiver that's going to be sort of overseeing that treatment regimen. And then with that more sort of complicated set of things going on in people's lives, it can sometimes be a little bit harder, go back to some of the barriers, to identify what the effects of the treatment are. So if you're in a standardized setting going to school every day for 12 years, you've got a pretty good gauge about, you know, how things are going when you're assessing the effects of medication. When you're now working 2 jobs and you're taking classes and your schedule changes from day to day and you've got different sorts of peer interactions, it's a little bit tricky to see, oh wow, where is the effect of this treatment that I'm taking?
Got it. And what impact does treatment non-adherence have on outcomes?
Yeah, well, when you stay on medicine, you do better. I mean, that's been shown in multiple settings. I mean, there have been a number of studies that have looked at insurance claims data and looked to see, okay, when you get a gap in your treatment, is that more related to other bad things that we can measure by looking at insurance claims versus when you stay on treatment? And the answer is yes. For example, injury and emergency room visits tend to go up when patients are not adherent. Those kinds of outcomes are important. There's others that, you know, there are a number of studies that have looked at especially ED visits and emergency department visits and the like. But those are serious, but they're also relatively low frequency kinds of events. There's also some data to suggest that more, I don't want to say meaningful, because staying out of the emergency department is definitely meaningful, but more sort of day-to-day impact has also been shown to track with adherence, such that when you are non-adherent, things like your work productivity change. And there are other studies with other kinds of similar outcomes. So, you know, there are lots of very good reasons to stay on your medication, or to try to think about ways that we can get over some of those barriers that lead to patients not staying on a steady regimen of their medication.
Got it. Got it. So what are the most common reasons? You talked about as they transition from childhood to adolescence and adulthood, that has an impact on adherence. But what are the most common reasons that people discontinue their medication? And are they really different for children and adults?
No, not really. I mean, the 2 big ones that emerge across age groups are lack of efficacy, or you know, that's a categorization in a study. Basically, the patient saying, "I don't think this works," like the example that I gave, and side effects. Those are reported across age groups and tend to be the main reasons why people quit or stop taking, discontinue their medicine. You know, I think it depends on how you look at those kinds of data. to interpret whether it's really good news or really bad news. The bad news is that, well, shoot, these treatments they're approved by the FDA, and yet the number one or number two reason why people don't stay on them is because they have too many side effects and they don't work. That seems to be a little bit of an oxymoron. Now, on the flip side of that, I mean, I think that they like I said before, they do work for the things that they are good at working for, and we have to think about fitting into a broader treatment plan what the medicine is. The good news with those two reasons is that it goes back to what we were talking about before of all the different options that we have. And one of the benefits, and I really liked your point about having prescribers have some level of just like general familiarity with a few different methylphenidate, a few different amphetamine-based products, because in general, if one formulation doesn't work, and if it's leading to a little bit, sleep issues or appetite suppression on the side effect side, or it's not working to control symptoms, then there's not a zero chance that if you switch a formulation or even switch from one stimulant to another, or even try a non-stimulant, you might actually see some effect. So again, we don't have a lot of data to guide those things. There are algorithms for how to step through and try different classes of medicine, but this comes back to clinical experience in guiding it. So I think the large number of options in that regard can be a positive thing. And then there are other reasons why patients or their caregivers give for discontinuing. But like I said, the two big ones are sort of suboptimal response and side effects.
Got it. Given that, and given that we can switch medication from one stimulant to another stimulant or one class to another class, what else can we do as clinicians to improve adherence?
Yeah, I think, and again, I am not somebody who's writing these prescriptions like you are. So the setting that I see patients in is a little bit different. And even with those who are writing medication prescriptions, there are different settings. But the thing that I would start with, always start with, is education, because I think too often you have patients coming in and they're or the caregivers, and they're getting a treatment plan without sufficient information about how that treatment plan maps on to the reasons they're coming in for help. And so it's hard for them to connect those dots, or we make it harder than it should be to connect those dots between what the expectations are, et cetera. We've also got to upfront think about what all those different barriers that I mentioned might be, and prep the patients for it as well. So I think that really, and there are other tools that can be used, I think, especially now, to help promote a better connection between the patient, their day-to-day treatment, and their provider, because this is not unique to ADHD. We would not expect people with lots of different chronic conditions, if they start a treatment, the doctor gives a prescription and says, "I'll see you in a month or 3 months." We're not going to expect too much about their engagement with their treatment. So we've got to step them through that a little bit more systematically. We've also got to meet patients and or their caregivers kind of where they're at. So we've got to think about, what's the age of the kid, what's the functioning level of the caregiver, what are the social circumstances, because in some cases, refilling that prescription of the kid's ADHD might be a very, very low on the priority list of major problems in their lives. And so we've got to think about that and how that's going to contribute to their adherence.
Great. I know one of the digital things that's helped me is in Nevada, they passed a law that you have to do all controlled substance prescriptions electronically. And I was initially just groaning and moaning about it because I'm a little bit technologically impaired, but it's been really helpful, because one of the steps, right, the patient getting to the pharmacy to drop off the prescription has been taken away, right? So we now have just the patient has to get there, which sometimes can be an issue too, but at least that's a little bit better.
Yeah, you solve 50% of the problem right there.
I did.
Or the state of Nevada did with your
Yes.
reluctant.
Yes, yeah, and we also have to, in most states, I think this happens, but in Nevada also, we have to monitor the prescription monitoring program and see what prescriptions people have picked up. And the last 3 months, we have to monitor it every 3 months, and that's been really helpful at looking at adherence. So some of those technologies have helped me, but there are a number of other things that have come online to help manage medical conditions, including telehealth. And just, can you talk a little bit about digital technologies? Because I know you're now at a digital company, and how these technologies can be used to support ADHD treatment adherence.
Yeah, I mean, as you know, I'm a huge proponent and have been doing work for a long time in sort of the application of technology to improve health in general, ADHD specifically. And we've just seen an explosion of products. I think one of the challenges is that there's a lot, we're still sort of learning our way in terms of separating the wheat from the chaff of these kinds of products, because there's hundreds of products, digital products, that tout different sorts of benefits for patients with ADHD or their parents. But to adherence specifically, and I think there are multiple ones of these products, but we have to focus on the ones where there's actually evidence. And there is there's one product now that there's been several studies done, and it's a pretty simple, bare bones text messaging platform. And the text messaging platform sends out reminders, notifications, and it's been shown to significantly improve adherence just to get that reminder. And I think part of it too is just it's not just the reminder, but it's this level of engagement with the patient. If they're more invested and they're more participatory in their treatment plan.
Wow. Scott, this has been a great discussion. I'm hoping that we have provided our audience with many clinical pearls for empowering their patients with ADHD and the caregivers, and to make informed treatment decisions. Do you have any concluding remarks that you'd like to share with our audience?
I mean, I know you and I could continue a discussion for a very long time, but I would say, thinking back on what we've talked about, if I had to pick, one or two things to say, like this is what I'd really like people to take home and remember about this. I think one is that our tool chest for managing ADHD is large, but it's sort of incumbent on us as clinicians to educate ourselves about the best ways to use all those different tools. And then I think also that just emphasizing the importance and the need for education and engagement, and whether we're doing that face-to-face, we have to do that face-to-face or televisits, but also taking advantage of technology to be able to just kind of get patients engaged and understand what they're bringing into the treatment setting and things like that, because we can't just see them, okay, you have ADHD, here's your prescription, see you later. That's just not going to work. And it's not, I mean, it's an oversimplification, but I think a little bit of extra effort on engagement and education can go a very long way.
I couldn't agree with you more. And as someone who does clinical trials, I say I can't even say hello in 15 minutes. So my minimum med visit is 30 minutes, because again, you've got to be able to educate and get information and find out what's going on with the teen, why they haven't taken their medication in 90 days.
Yep.
So thanks again, Scott. This has been a great discussion, and I think we could go on and on. But I'm going to summarize now with our SMART goals. And SMART stands for specific, measurable, attainable, relevant, and timely. And that's what we hope our audience will take from this presentation and apply in practice. We want folks to be able to create a partnership with patients and caregivers to inform their treatment planning, and hopefully that will optimize treatment outcomes. We want them to routinely assess treatment adherence in their patients and develop treatment plans for ADHD that consider the use of digital health interventions to support adherence. And I think COVID has gone a long way to propel us into that digital arena. This CME Outfitters Snack is one of a 4-part series, and we hope that you'll take advantage of all the short and focused activities in the series. Scott, thank you again for joining me today. It's been great to see you. And thanks to our audience for listening to this CME activity. Be safe and take care of yourselves so you can provide the best care for your patients with ADHD.